We can start.
Yes, ma'am. We are live now. So, good evening, delegates and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on AMOGS Medical Disorders Committee with OGSSI. So, let me introduce the president of OGSSI, Dr. K.S. Jairani, ma'am. Ma'am is the senior consultant of reproductive medicine and director of Akash Fertility Center and Hospital. And currently, ma'am is president OGSSI and treasurer of TAPISAR. And the ma'am has numerous number of awards. I welcome you, ma'am, and I hand over the session.
Thank you for the introduction. I have the great pleasure and honor to welcome you all for this joint venture of AMOGS Medical Disorders Committee along with our OGSSI to have this webinar on glycemic disorders in pregnancy. And we have a very dynamic past breast committee chairperson, Dr. Sneha Boyer, who is the main convener, who is the main mastermind behind this webinar. And along with AMOGS, we have a great pride and pleasure and honor to have this webinar. We'll start the webinar with our traditional Tamil Thai Varthu. Sahiti, can I have the... Audio is not there, Sahiti.
Okay, ma'am. I'll just...
So thank you, Tamil. Thank you for this Varthu, which have been blessing from the Tamil Thai. And traditionally, we know the light is the light which gives the brightness to the knowledge. And we have our traditional lightning of Kuthuvilakku to start anything for the knowledge beginning, to dispel the ignorance of darkness. So we start with a Kuthuvilakku, which is a traditional form of starting any good things. So with this lightning of Kuthuvilakku, we move to a very important part, that the prayer, the OGSSI prayer. May I request my Honorary Secretary, Dr. Kundavi Shankar, who is a renowned senior consultant of MMM, who is a leading specialist of an ART specialist for more than 25 years, and our Honorary Secretary of OGSSI. Over to you, Kundavi, to deliver the OGSSI prayer.
Thank you. Thank you, God. In humility we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings, to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, Kundavai. So now we are moving to the inauguration. I have the great pleasure and pride and honor to welcome the chief guest, Dr. Rajendra Singh Paradesi, sir, who is well known for all over Roxy and all over South India for his dynamic inspiration, being the president of AMOGS, who has got a lot of knowledge, lot of educational activities, being presenting paper, more than 28 papers, national and international, and who was the faculty for ASUOG from 2011 onwards, and has been a presidential post of many prestigious societies, and has been the past vice president of FOXY, and also the vice president of AMOGS, and now he's the president of AMOGS. Over to you, sir, for blessing our webinar.
Thank you, Dr. Jayarani. Good evening, everybody. Respected Dr. Sujata Dalvi, Dr. Kiran Kurtakoti, Dr. Lakshmi Srikhande, Dr. Ashok Kumar, Dr. Jayarani Kamraj, Dr. Kundavi Shankar, Dr. Sneha Boyar. First, I wish to congratulate Dr. Sneha Boyar and Dr. Jayarani Kamraj, because they organized this joint venture of AMOGS and OGSSI, which is a feast. I think that it is a feast, academic feast on GDM with practical tips. GDM, we all know, is also increasing day by day and really a challenging task. Pregnant women with any form of dysglycemia experience higher morbidity and mortality rates compared with normal pregnancy. We are very much concerned about to reduce maternal mortality rate. The mortality rate in pregnant women with type 1 diabetes mellitus is 2-fold to 3-fold higher than for non-pregnant women with type 1, and 5 to 20 times higher than the general obstetric patient. That's why diabetes mellitus GDM is very important. With the galaxy of speakers, moderators, panelists, chairperson, I think this will be a great event. I wish every success to Dr. Sneha Boyar and Dr. Jayarani Kamraj for their future endeavor in FOXY. Wishing every success to this webinar. Thank you so much for inviting me.
Thank you, sir. Thank you, sir. Thank you for your words of wisdom, and thank you for being with us in midst of your busy schedule to bless us being as a chief guest. And I have the great pleasure and honor to welcome Madam Dr. Sujata Dalvi, who is the Secretary of AMOGS. Madam is the Joint Associate Editor of Jogi, and she's the Clinical Secretary of Mumbai OBGYN Society, and she's the Honorary Clinical Associate and also the Consultant of the Nauroji Wadia Maternity and Jayajivaram Hospital. Madam.
So Jairani, that should be okay enough. Yeah.
We welcome you, ma'am, for your...
Okay. Thank you. Thank you for the kind introduction. So as a Secretary of AMOGS, I would like to welcome one and all for this webinar, which is organized by AMOGS Medical Disorder Committee with OGSSI. We have a Medical Disorder Committee Chairperson, Dr. Sneha Boyar, who is a convener of this program, along with OGSSI President, Dr. Jayarani Kamraj. Both of them are very vibrant and very energetic as such. I would also like to acknowledge the presence of Dr. Rajendra Singh Paradesi, President of AMOGS, who is always an encouraging figure. And he gave you the details of how important diabetes in pregnancy is. And I'm sure everybody who has logged in is going to learn a lot after this webinar. I would also like to acknowledge our guest of honor, Dr. Kiran Kurtakoti, who is the first vice president. He would be taking over as the president of AMOGS in February 2024. Would also like to acknowledge ICOG office bearer, Dr. Lakshmi Srikhande, chair, and of course, Dr. Ashok Kumar, the secretary of ICOG. And I wish all the best wishes for today's webinar, and also best wishes to Jairani and Sneha Boyar for their future endeavor in FOXY. Thank you so much.
Thank you, ma'am. Thank you.
Thank you so much.
Over to you, Sneha.
First of all, a very good evening to all of you. I would like to thank my president, respected Dr. Paradesi sir, AMOGS president, and Madam Sujata Dalvi, the secretary of AMOGS. Of course, I would like to also thank ICOG chair, Dr. Lakshmi Srikhande, and secretary, Dr. Ashok Kumar, Of course, past president of AMOGS, immediate past president, Dr. Nandita Palsekar, and the president-elect, Dr. Kiran Kartakoti, who, because of their busy schedule, they could not join. But yes, I welcome them and thank them for the opportunity. I thank Jairani and her team, OGSSI, all the esteemed faculties, especially Dr. Andalakshi Madam, whom I have been associated since long, since I was a press committee chairperson, and we have had many activities together. Madam Premlatha and all the panelists and chairperson who are, being the active part of this webinar. Dr. Kundavi Shankar, special thanks to you for taking all the efforts. I thank all of you once again, and thank you for gracing the inauguration of this program. And with this, blessings of God and blessings of all of you, we would like to march ahead towards the academic session. Thank you so much, and over to you once again, Dr. Jairani.
Thank you, Sneha. Thank you for your words, and thank you, sir, Pardesi sir, and Dr. Sujata Dalvi for being with us, and also all the other guests of honor, Dr. Kiran sir, for blessing us. And thank you so much, Sneha, for organizing this wonderful webinar. We welcome you all, the senior faculties, Dr. Rajalaksha Madam, Premlata Vasandamani, and all our loving EC members, as well as all the office bearers of OGSSI, AMOGS, for being in this webinar. And we welcome all the delegates too. And we'll start the academic session with the first session. Sneha, can you introduce the chairpersons of the first session?
Yes. So we have the first session to be started with a speech by none other than Madam Anjalakshi Chandrasekhar, and the chairpersons for this session are Dr. Vasanthamani, who is the consultant in Parvati Amal Hospital. Her CV is highly decorated, where she has got many awards as well, best performance from the Department of Health and Family Welfare, and also award for Environmental Center for the year 2018. She has held the official post as Dean of the Government Villupuram and Kilpock Medical College and ADMA Secretary Selection Committee. And we welcome you, Madam Vasanthamani. Next.
Thank you, ma'am. Thank you for your kind words.
I welcome Dr. Deepa Thangamani as the next chairperson for this session. And yes, Dr. Deepa is a consultant in Apollo First Medical Hospital, Chennai, and she's a consultant at Tamarai Fertility Solutions Exclusives, Chennai. She has held she's holding the post currently a Joint Secretary ATN RCOG and Joint Secretary CMS Chennai Menopause Society. Welcome, Dr. Deepa Thangamani.
Thank you, ma'am.
Forum, I hand over to you to introduce Madam Anjalakshi.
So it's thank you, ma'am. It's my great pleasure to introduce Anjalakshi Madam, who is a renowned expert in the field of gestational diabetes, and it's a apt topic for the madam. She is a senior consultant Chennai. She is a founder president for TNFOC, and she is a past president OGSSI. She is a governing council member for DIPSI. She will guide us through the intricacies of this gestational diabetes and shed light on the latest development and best practices in diagnosing GDM. She's an over to Madam. Anjalakshi Madam.
Madam, please unmute yourself. Anjalakshi Madam, please unmute yourself.
Thank you, Chairperson. Good evening. First of all, I want to congratulate Dr. Jairani and Dr. Sneha Buyer for arranging this webinar as a joint venture. And also, I want to convey my best wishes and blessings to both of them for their ambition to reach their ambition in the POXI. Okay, with this, I start off how to diagnose the gestational diabetes mellitus. Please phone number. Huh?
Yeah, make it full screen, madam.
That's what. No.
Madam, you can go to slideshow, madam. Up.
Slideshow only I'm
Slideshow and from
going.
beginning. Mail. Ah.
Now is it
Yes,
okay?
madam. Yes, madam.
Yes. Okay. Okay. So I always want to start the topic of gestational diabetes mellitus with the quote by Duncan, who has said in 1882 that diabetes may develop during pregnancy and cease with the termination of pregnancy, recurring sometimes after that, and hydramnios is common, that pregnancy is very liable to be interrupted by the death of the fetus, and the dead child is often abnormal. So this quote describe all the problem, the morbidity, mortality that occurs when there is a hyperglycemia during pregnancy. So still it holds very good. If you don't recognize that, you will come across all these problems. But if you recognize and treat it, you get the 100% salvage. So I will go to a little bit of the pathophysiology. The fetus is a parasite continuously draining glucose, that is nutrients, from the intermittently eating host, the mother. The placenta, which arises de novo, is a temporary endocrine organ, elaborating the contra-insulin hormones like estrogen, progesterone, cortisol, and HPL. And the maternal nutrients, they pass through the placenta, but maternal insulin do not cross the placenta. Maternal insulin is destroyed by the enzyme insulinase, which is present in the placenta. So the mother, she is the intermittently eating host. She has a fixed state characterized by facilitated anabolism due to delayed gastric emptying and sluggishness of the enteroinsular axis. And she has a fasting state which is characterized by accelerated starvation due to the substrate deficiency which is being diverted to the fetus, and there is no substrate for the gluconeogenesis. So mother diverts herself to lipolysis and ketogenesis, which is seen in a starvation. So she goes to a state of accelerated starvation. So so what happens when there is a glucose intolerance during pregnancy? When it is seen in the first trimester, there is the affection of the organogenesis. And in the second trimester, behavioral changes and the bony abnormalities. And in the third trimester, it gives rise to problems in the anthropometric measurements, the metabolic effects, and later on it results in the childhood obesity and type 2 diabetes and so on. So you will see the established diabetes mellitus, when it is marching through pregnancy, it can affect all the 3 trimesters depending upon the control. So this is known as a fuel-mediated teratogenicity. So this is the Pedersen's and Frank's hypothesis. That is, when the mother has less insulin, there is increased nutrient in the mother, glucose, amino acids, lipase. And these mixed nutrients, they pass through the placenta and causes increased insulin secretion in the fetus, which results in the macrosomia, and that results in the neonate hypoglycemia, and in the adolescent period, obesity, IGT, and diabetes in the earlier age. So these are the various effects that can occur on the mother, on the fetus, and on the neonate. So coming on to the gestational diabetes, it is defined as a carbohydrate intolerance of any severity with recognition or onset during pregnancy, irrespective of treatment with diet or insulin. The importance of GDM is 2 generations are at the risk of developing future diabetes. That is, the women with GDM and also her children. So diabetes begets diabetes. So the GDM can be viewed as, because of the definition, it can be viewed as an unidentified pre-existing disease. That is, you may be diagnosing it for the first time during pregnancy, that is already a diabetic. Or it may be an unmasking of a compensated metabolic abnormality by the added stress of pregnancy. A good example is a polycystic ovarian disease, where there is an insulin resistance. With that, there is a super added stress of pregnancy is there. She may get a GDM. The GDM may get precipitated. Or it can be a direct consequences of the altered maternal metabolism stemming from the changing hormonal milieu of pregnancy itself. So it could be either of the 3. So if you take a features of the GDM, they are largely asymptomatic, unrecognized and untreated, associated with increased perinatal mortality, morbidity, and maternal morbidity. And AGT, that is abdominal glucose tolerance during pregnancy, is teratogenic. If you are recognizing this AGT and treat, it gives a good fetal outcome. So now going on to the diagnosis of GDM. How we are going to diagnose GDM? There is a global incidence of GDM. It's very difficult to estimate because of the lack of uniform diagnostic criteria. There are so many criteria are there. Since we don't have a uniform criteria, it is very difficult to find out the incidence of GDM. The HAPO study, it has demonstrated that there is a continuous association of maternal glucose levels with adverse pregnancy outcome throughout pregnancy. And there is no global consensus about the appropriate screening or diagnostic test. So this is a situation we are. So a number of screening procedures and diagnostic criteria are followed in different countries. ADA, WHO, Canadian Diabetic Association, NDDG, Australian criteria, and now the IADPSG. So we have so many diagnostic procedures we have for this. And if you look at this cutoff values, see the ADA, the ACOG, they use 100 gram glucose GTT, and the values are there 95, 180, 155, 140. That is up to 3 hours you have to do the GTT. Then you have the WHO where they use 75 gram glucose load, and fasting 126 is taken as a diabetes, and 2/140 is taken as a impaired glucose tolerance. The impaired glucose tolerance during pregnancy is known as gestational diabetes mellitus. And you have to look at the IADPSG criteria where it is again done with the 75 grams glucose load, fasting 92, 1 hour 180, and 2 hour 153. Any two values should meet to diagnose the GDM. So what is fit for us? For our Indian setting, we have the DIPSI criteria for the diagnosis of GDM. So to diagnose who you will be testing, and how you will test, and when will you do the test. These 3 questions we have to answer. So if you look at the ethnicity of the Indian, screening is essential in all pregnant women in India, as the Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy when compared to the Caucasian women. So we are ethnically prone. So, and our the propensity is 11-fold than that of the Western people. So every one of us should have the screening because of the ethnicity. So the universally all pregnant women should be screened for GDM. Anything? Next is the what test we are going to do. A single test procedure for diagnosis of GDM. All diagnostic criteria which I showed you, the chart, they require the women to be fasting. For a successful universal screening, the procedure should not impose any restriction. So a single test 2 hours after 75 gram glucose in non-fasting state, irrespective of the last meal, can make the diagnostic procedure simple, feasible, and economical. This test serves both screening and diagnostic and causes least disturbance to a pregnant woman's routine activities and avoids the inconvenience of fasting in the pregnant women. It was found that there was no significant difference in the plasma glucose level between 75 gram glucose testing in the fasting and non-fasting state, irrespective of the last meal timing. If you understand the physiology, then when you take a glucose challenge, there will be a surge of insulin and the blood sugar will be maintained normal even after taking food. So performing this test in the non-fasting state is rational, as glucose concentrations are affected little by the time since the last meal in a normal glucose tolerant women, whereas it affects women with GDM. Whenever there is an insulin deficiency or dysfunction, then it affects. So the non-fasting 2 hour post 75 gram glucose correctly identify the subjects with GDM and strongly predict the adverse outcome both for the mother and their offspring. Thus, A single step procedure performed irrespective of the last meal timing seems to be a more rational and patient friendly approach. This study actually we have conducted when I was in the Institute of Obstetrics and Gynecology. For about 1,000 people, we did the test, and we have found the values are both in the fasting and in the non-fasting state. They are normal, they are safe in an affected individual, and it is normal in a non-GDM person. So by following the usual recommendation for screening between 24 to 28 weeks gestation, that is a decade or two ago, before that, we were using only 24 to 20 weeks gestation screening. And by doing this, many early onset GDM and pre-pregnant unidentified DM, they can be missed, which may adversely affect the fetal outcome. So Seshia et al. In a study has detected 16.3% of the glucose intolerance within 6 weeks of pregnancy. There are 2 more studies are there which reported about 40 to 66% of women with GDM, they can be detected early during pregnancy. So this is regarding when we have to test. Okay, so it is safe to screen for GDM during early weeks of pregnancy, as by early detection of glucose intolerance during pregnancy and adequate care to the antenatal women, a good fetal outcome can be achieved similar to that of the normal gestational tolerant women. If this test is normal in first trimester, then we have to repeat the test around 24 to 28 weeks, and again repeat around 32 to 34 weeks. And when the consultant feels whenever it is necessary, it can be repeated. Only thing you have to remember, there should be an interval of 6 weeks between the 2 tests. So it has been suggested that women at high risk should be screened as soon as the pregnancy is confirmed. So how to do the test, the methodology? It's a single step procedure, and now the Ministry of Health, the Government of India recommends this, where you give 75 grams of glucose given orally after dissolving in approximately 300 ml of water, whether the pregnant woman comes in fasting or non-fasting state, irrespective of our last meal timing, just ask her to take the glucose solution. The intake of solution has to be completed within 5 to 10 minutes. And a plasma standardized glucometer should be used to evaluate the plasma glucose level 2 hours after the oral glucose load. If vomiting occurs within 30 minutes of the oral glucose intake, the test has to be repeated the next day. Suppose if the vomiting occurs after 30 minutes, you continue with the test and do the 2-hour glucose value, and you can diagnose. The threshold, now I'm coming to the threshold. The threshold for the plasma glucose level is equal to or more than 140 milligrams for the diagnosis of gestational diabetes mellitus. So the universal screening we have to do, and we have to start doing it at the early weeks of pregnancy itself, and then you have to do a single test procedure, that is a fasting or non-fasting GTT with a cutoff value of 140 or above 140 is taken, and diagnosis of GDM is being made. So there should not be any confusion. You need not, as far as India is concerned, this is the test which is being approved by the government of India. So if you don't do the test, then you will be legally liable. So you do this test and don't get confused with the so many other existing criteria. So this is the government of India's approving this. So one-step test is feasible as a routine test during antenatal care for all pregnant women. The next is government of Tamil Nadu approving the single test. They said the 2-step procedure requiring attendance on 2 separate occasions is often not feasible. So do a single step procedure. So what are the advantages of this DIPSI criteria? Pregnant women, they need not be fasting. It causes least disturbance in a pregnant woman's routine activities, and diagnosis of GDM with 2-hour post-glucose equal to or more than 140 milligram and treatment of worthwhile with a decreased macrosomia rate, fewer emergency cesarean sections, serious perinatal morbidity, and may also improve the women's health-related quality of life. If in the non-pregnant stage, the 2-hour plasma glucose more than 140, that is impaired glucose tolerance, it is considered abnormal in a non-pregnant stage. Okay, this IGT, impaired glucose tolerance, they are prone for microvascular and macrovascular complications. So we treat in a non-pregnant stage. When that is so, why not we consider this abnormal during pregnancy? This is a food for thought. So the next is comparing all the international organization recommendations and our national guidelines. Our national guidelines is Ministry of Health and Family Welfare, Government of India recommends a single test procedure for diagnosing GDM. The international guidelines, WHO recommendations, WHO accepts a single test procedure of DIPSI to diagnose GDM. WHO also made a few important and pertinent observations with regard to GDM testing. That is, OGTT is resource intensive, and in many health services, especially in low resource settings, they are not able to routinely perform the OGTT in pregnant women. In these circumstances, many health services, they do not test for hyperglycemia in pregnancy. So for a pregnant woman, the request to attend the fasting stage for a blood test may not be realistic because of the long travel distance to the clinic and in the many parts of the world, not only in India, in many parts of the world, and also increased tendency to nausea in the fasting stage. So all these things recommend the single step procedure. Consequently, a non-fasting testing may be the only practical option. So the laboratory glucose measurement is often not available. Again, the lab, sending the blood to the lab, it goes through many steps. So there may be so many drops and ups will be there. And the testing with a portable blood glucose meter may be an option. So DIPSI recommends the glucometers should be plasma glucose calibrated glucometers. So the International Federation of Obstetrics and Gynecology, PIGO, and International Diabetic Federation, IDF, both of them, they approved the single test procedure. So the disadvantages and inadequacy of this, the other one which is being commonly used even in India, many people, they still follow the IAD-PSD criteria. So what are the disadvantages of this IAD-PSD criteria? WHO has passed a comment saying that there is a lukewarm endorsement of the IAD-PSD criteria, describe the quality of evidence for its recommendation as very low and the strength of its recommendation as weak. This is the comment by the WHO on the IAD-PSD. And center-to-center differences occurs in GDM frequency and the relative diagnostic importance of fasting 1 hour, 2 hour glucose level. And this may impact the strategies used for the diagnosis of GDM. So the variations may influence the future development of optimal cost-effective strategies for detection and treatment of GDM by following the IAD-PSD criteria. The low diagnostic rate of fasting blood glucose has been reported in Asian Indians with a fasting plasma glucose of 5.1 millimole, that is 92 milligrams, diagnosing only 24% of the GDM by the IAD-PSD criteria. IAD-PSD says fasting less than 92. So, okay, only 24% of the GDM can be diagnosed with this fasting level. Importantly, even at centers that accepted the IAD-PSD recommendation, the approach varies and there needs revision for standardization of the strategy for diagnosing GDM. So the concern is IAD-PSD criteria may overdiagnose GDM without any clear clinical benefits. Screening strategy based on IAD-PSD criteria may be cost effective for high resource settings, but probably it is too costly for most of the countries. A1C is not possible to perform in the less resource countries, not only because it is expensive, but also due to the lack of technically qualified staff. The cost and the standardization of A1C testing are issues for consideration. So we cannot, the A1C is out of question for the diagnosis of GDM. there is a no high quality evidence that women and their fetuses, they benefit from treatment if only the fasting value is abnormal. RCT has shown benefit of treating GDM women identified primarily by post-load values. So in relation to the fasting plasma glucose, there is a considerable variability between countries noted in the APO study, with fasting plasma glucose diagnosing only 24% of the GDM, and also in women in Bangkok and 26% in the Hong Kong, compared with 71% in some US centers. The most the tragic part is in the IADPS study, that APO study, India was not included. So the countries which included was Bangkok and the Hong Kong, where the fasting plasma glucose has a sensitivity of only 24 to 26%. So the community health center, they need a simple economical test where 70% and more of the populations, they are living in the rural area. So the guidelines and the diagnostic criteria, which are simple and feasible on the ground, is very important. So to summarize, GDM pregnancy is diabetogenic and it unmasks minor degrees of carbohydrate intolerance if the islet cell reserve is poor, and carbohydrate intolerance is asymptomatic, and if not treated, increases the perinatal mortality and morbidity. If detected and treated, perinatal outcome improves, and single-step diagnostic test with 75 gram glucose in non-fasting state with a cutoff value of more than or equal to 140 milligram percent helps in the diagnosis. Screening as early as 9 to 10 weeks gestation is recommended, and screening should be universal, and screening should be repeated if found negative at 28 and 32 weeks. And the goal of therapy is to keep the fasting blood sugar less than 90 and postprandial less than 120. So my next speaker will be talking on the management. So this is the target for the therapy. So with this, I thank the organizers for this wonderful opportunity. Thank you very much.
Thank you, madam. Thank you for your elaborated history talk about how to diagnose GDM in early pregnancy. And right from beginning, we are doing DIPSI and all the various tests from 24 to 28 weeks. Now you have recommended to do it as early in pregnancy, up to even 8 to 9 weeks. And why you want to do 8 to 9 weeks? Because after some time you want to break the cycle of GDM and the damage done by GDM to the intrauterine fetus, and to put a full stop to diabetes in future generations.
Yes.
So as per your professor, Dr. Sesaya sir is discussing in our DIPSI conference, that if you diagnose early pregnancy, even at 7 to 8 weeks, the damage done by the hyperglycemia to fetal islet cells will be prevented, so that the baby will not have diabetes when it becomes at the age of 40 or 40 plus. So
you can prevent the GDM itself. You can prevent the GDM in the mother itself. To prevent the hyperinsulinism. Yes. Yes, ma.
Yes,
go ahead.
And moreover, you have compared that IAD PSG method, and as compared to DIPSI, it has one-step test. That is, irrespective of the fasting state, the patient comes. If you give 75 gram glucose, only one blood test will have a conclusion saying that whether they are over diabetes or GDM or not GDM, so that patient can go through with a peace of mind that this is not having GDM. And one more question, ma'am. If they come at early weeks, at 9 weeks and 10 weeks, we do DIPSI. And if it is negative, is it necessary to repeat at 20 weeks and 32 weeks as previously advised?
Yes. We have to repeat. We have to repeat. See, at the first trimester, that is earlier week, there is a fetal hyperinsulinism. That only you want to prevent. Okay. If you prevent that, you will prevent the effects on the baby. But the insulin resistance is added by the hormones of pregnancy, which increases, which reaches a peak around 20 to 24 weeks. So that is the time also you have, suppose if it is negative, in the earlier weeks, you have to repeat it in the second trimester. Again, if negative, you have to repeat, because the hormones, they keep on increasing. At any stage, the balance can be tilted and mother can show hyperglycemia. So you have to screen in all 3 trimesters. Okay.
One more question. Yeah, one more question, ma'am. If you miss GDM at 30 to 34 weeks, the damage will be much more than you miss in early diagnosis. Is it so, ma'am?
Suppose no, if the patient is developing hyperglycemia only at the 3rd trimester, so she will go for the anthropometric changes and macrosomia will result, which actually starts from the 2nd trimester. Suppose if it is an earlier diabetes itself, then the damage will be much more actually, definitely much more. The vasculature will be affected, so you'll have increased incidence of preeclampsia, and because of that fetal wastage, so the problems will be much earlier and you will have the more perinatal effect. Okay.
Thank you, ma'am. Thank you
Right.
for your, thank you very much. And
Right.
thank you
Thank you,
for the
ma'am.
opportunity. Thank you for, thank you, Oxy.
Thank you, Anjalakshmi madam, for your insightful and informative presentation on diagnosing GDM, madam.
Yes,
You just show the passion in this topic, madam. Thank you so much, ma'am.
thank you much. Thank you, Chairperson.
Taiti, can you just have the chairperson CV, Dr. Josephine and Dr. Premlata, madam? Dr. Sneha?
Yes, yes. So it's my privilege to welcome Madam Premlata for her talk on the management of hyperglycemia in pregnancy. And I welcome the chairpersons, Dr. Josephine Rosie, who is the head of the Department of OGSSI in the Madha Medical College Hospital in Chennai. And she's got lots and lots of achievements. She has published 2 international and 2 national she has published her articles in the international as well as national journals, and she has published a poster presentation in RCOG Congress 2020. And of course, she's a UG and PG teacher of OGSSI. And I welcome Dr. Josephine. And with this, again, I welcome the speaker Premlata and the chairperson Premlata madam, who is the head of department and professor of Obstetrics department, Tagore Medical College and Hospital. She's the retired medical professor of MMC and KGS, project officer of KGS, and she's got 28 years of teaching experience. Madam Premlata PV, welcome to chair the session, and over to you for introducing the speaker, Madam Premlata.
Thank you, madam. It has been great pleasure for me to introduce Dr. R. Premlata, who is almost my colleague. Though she is senior to me, she is a colleague. We have been working together for a long time. She is past president of OGSSI. She is consultant, head of the Department of OG, Mehta Multispeciality in Chennai, and she is former professor of obstetric gynecology and director in charge in Institute of Obstetric Gynecology, Madras Medical College, and also she is alumni from Madurai Medical College, and she has presented many papers in the national and international conferences and published articles in various journals. And she is an expertise in microsurgery, interest in infertility and laparoscopy. She has authorized a book which has been now the Veda of OG, for all the undergraduates. We are also following that green. We say it as a green book.
Thank you, Dr. P.B. Premlata.
Over to you, madam.
Thank you. Can I share my screen? I have this. Thank you. At outmost, I want to thank the OGSSI President Dr. Jairani and Dr. Am I audible?
Yes.
Okay.
Yes, yes.
And Dr. Shreya, who is the chairperson of the MOGS Medical Disorders Committee, for the wonderful opportunity to talk on management of hyperglycemia and pregnancy today. Dr. Anjalakshmi Madam has given a very detailed about the diagnosis of diabetes in pregnancy. As we all know, hyperglycemia and pregnancy could be due to a pre-gestational or over diabetes, or it can be diagnosed during pregnancy. And our plan of management is mainly control of hyperglycemia, pre-conception care, antenatal care, and postnatal care. Our idea is to have an optimum maternal and fetal well-being and to have a long-term follow-up to prevent. As Madam was telling, diabetes begets diabetes, and our aim is to prevent the long-term morbidity. So the effect of pre-gestation or over diabetes or pregnancy, in a nutshell, I will go through.
Ma'am, your slides, ma'am, we are not able to see your slides.
Slides, really, yeah.
No, madam.
Madam, your screen is not shared as it.
Share screen per layer.
Can you see the share screen icon?
Can you see now?
Yes, yes, madam.
Can you see now?
It is showing sharing the screen. Yes, perfect.
Yes.
Yeah.
Yeah.
Yes.
Madam, full screen.
Ma'am, please make it full screen.
Yeah. Okay, ma'am. In pre-gestational diabetes, when the hemoglobin A1C concentration is more than 12%, the incidence of spontaneous abortion are very high. In untreated diabetes, it's found to be very high, and preterm deliveries is around 19 to 26%, and majority are indicator or induced preterm births. And unexplained fetal death is around 3 to 4 times higher. Preeclampsia 3 to 4 times higher in case of pre-gestation diabetes, hydramnios, and infections. As we all know, candida infections, urinary tract infection, and respiratory tract infection, and puerperal infections are more common in pre-diabetes complicated pregnancy. Whenever the woman is having pre-gestation diabetes along with diabetic nephropathy, the pregnancy, during pregnancy, the renal impairment may have accelerated progression of the disease. And if they have diabetic retinopathy, proliferative retinopathy, women with proliferative retinopathy, if they have vaginal delivery, can be associated with retinal and vitreous hemorrhage. And diabetic neuropathy women can have diabetic gastropathy, which can lead to increased nausea, vomiting, nutritional problems, and difficulty in glucose control. Diabetic ketoacidosis can occur in women with hyperemesis and infection. And during labor, we all know, because of macrosomia, shoulder dystocia, increased instrumental delivery, cesarean delivery, uterine atony, and PPH occur. And pre-gestation diabetes, as I told earlier, when the hemoglobin A1, in neonatal complications, when the hemoglobin A1C is less than 7%, no greater risk of congenital malformation. But if it is 7 to 8.5%, 5% risk for congenital anomalies are there. When the hemoglobin A1C is more than 10%, risk of anomalies rise to 22%. And alter fetal growth, both macrosomia and fetal growth retardation can occur in pre-gestation diabetes. When there is associated congenital malformation or maternal vascular disease, IUGR can occur, and fetal overgrowth is more typical of pre-gestation diabetes also. And metabolic disturbances in babies are hypoglycemia, hypercalcemia, hyperbilirubinemia, polycythemia can occur, and fetal oxygenation problems can lead on to sudden fetal demise, chronic fetal hypoxia, and respiratory distress syndrome. And babies can develop, infants can develop cardiomyopathy and long-term sequelae. They are supposed to have delayed cognitive language development. Delays are found to be present in women and babies who have developed delivered by diabetic mothers, and they can develop diabetes in adult life. This is about pre-gestation diabetes. So in nutshell, you can say because of preeclampsia, induction of labor is increased rate, increased cesarean section rate, operative delivery rate, and complications are increased. And postpartum, they can go for type 2 diabetes in later life, and recurrent GDM up to 40% are found to be there. Congenital anomalies, fetal cardiac and nervous, central nervous system anomalies are found to be increased, and large for gestation age babies, macrosomia can occur. And all this I have enumerated later. And long-term sequelae for the babies are increased obesity, type 1 diabetes, type 2 diabetes, and metabolic syndrome. So since we know these are the complications in pre-gestation diabetes, compared to the gestation diabetes, same fetal effects can occur, but gestation diabetes do not have substantially higher rate of anomalies compared to the pre-gestation diabetes, but they have a higher frequency of hypertension, preeclampsia, preterm birth, macrosomia, and same complications of shoulder dystocia, operative vaginal and cesarean delivery. And similar to pre-gestation diabetes, they have a higher risk of stillbirth, neonatal respiratory distress, low 1-minute ABGA score, and they are found to have greater admission rate to NICU. Excessive gestation weight gain is more common with women with gestation diabetes and confers an additional risk for fetal macrosomia. Neonatal metabolic sequences are also more common, like hyperglycemia, hyperbilirubinemia, and polycythemia. So coming to the management of hyperglycemia, these are the various maternal and fetal complications. So our guiding principles are that we have to manage hyperglycemia should be controlled, and we should have a euglycemic state. So the guiding principle of hyperglycemia, whenever a woman is found to be diagnosed as GDM for the first time, they should be started on medical nutrition therapy. Madam was told the various methodology to diagnose, and the one-step procedure is the mantra. And once the woman has found to be having GDM, we have to advise her on medical nutrition therapy. After 2 weeks of medical nutrition therapy, at 2 hours postprandial glucose level, if it is less than 120, we have to continue medical nutrition therapy. Up to 28 weeks, we can check once in 2 weeks. After 28 weeks, we have to monitor every weekly. Insulin therapy is the accepted management in women with diabetes and not controlled on medical nutrition therapy in 2 weeks. So what is the treatment of medical nutrition therapy? The principles of GDM medical nutrition therapy primarily involves a carbohydrate controlled balanced meal plan. So the women should have optimal nutrition for both maternal and fetal health, and the carbohydrates should be controlled. Adequate energy should be for appropriate gestation weight gain, and you have to have maintenance normal glycemia. The nutrition assessment in GDM should be individualized. It depends upon the body mass index and the desirable weight gain during pregnancy. So when we talk about carbohydrates, large amount of carbohydrates when eaten at one time lead to high postprandial blood sugar. So it should be avoided, and we should advise the women to take carbohydrate foods in a spreading manner. So meals should be in a spread pattern, and she should have 3 small meals and 2 to 3 snacks each day instead of taking 3 large meals. And complex carbohydrates should be preferred, like whole grain cereals like oats, bajra, jowar, ragi, whole pulses, vegetables, fruits with skins should be preferred over simple carbohydrates. Like food, food with high glycemic index like sugar, honey, and all should be refined white flour should be avoided. And these women, medical nutrition therapy is coming to fat, saturated fat, which is being the source from ghee, butter, coconut oil, palm oil, red meat. There should be less than 10% of the total calories. And protein recommend should be increased, which is more than additional 23 grams are needed. And these should be from 3 servings of protein foods. And the protein foods which we should advise are milk products, egg, fish, chicken, pulses, nuts, like that. And high fiber content should be advised because the high fiber, soluble fiber helps to control blood sugar by delaying the gastric emptying. So it delays the gastric emptying. So entry of glucose in the bloodstream is decreased. So high fiber food should be advised. So fiber which is rich in like oat bran, legumes, and whole pulses should be advised, and fruits with thin should be advised to take. So medical nutrition therapy also depends upon the body mass index, and we may have to advise the women depending on her type of activity like sedentary work, moderate work, or heavy work. And nutritionist advice will be advisable in women who are having obesity to look for the calorie requirement. And coming in the medical nutrition therapy, we have to advise about the exercise. Around 30 minutes of mild to moderate exercise daily helps in improving the glycemic control. It improves the insulin sensitivity. So one of the important things is exercise. We have to advise her. Once they are diagnosed GDM, they are scared. They don't want to walk. They are very much worried. We have to advise them to do a simple walking exercise, which improves the insulin sensitivity at the skeletal muscle level. Light exercise in the form of walking, especially after meal also, they say helps in reducing the postprandial glucose levels. Pharmacotherapy, coming to the pharmacotherapy, when do we give to the pharmacotherapy? After a woman put on medical nutrition therapy. We have to review her after 2 weeks. And 2 weeks, when we do a fasting and postprandial blood sugar should be done. If the postprandial sugar ideally should be less than 90 milligram, and the 2 blood sugar should be less than 120 milligram. So insulin therapy has been remained the gold standard in the treatment of GDM and pre-gestation diabetes. The insulin which we give is, as per the NHM, is the premix insulin of 30-70 insulin, which is given subcutaneously 30 minutes before breakfast once a dose will be initially started. If the 2-hour postprandial glucose is more than 200 milligram, we have to straight away start around 8 units of mixed insulin. And these women should be monitored every 3rd day when they are on insulin therapy, or and we have to do fasting and postprandial blood sugar every 3rd day. And the requirement of insulin increases with gestation age. As the women gestation age advances, the insulin requirement is increased. Usually the dose of insulin varies from 0.6 to 1 unit per kg per day. So the total insulin requirement should be can be given in 2 different doses, like 2/3 in the morning and 1/3 at night. So these are the basic guidelines. So when we have the guidelines of glucose control, when we start when the postprandial blood sugar is found to be between 120 to 160, we start by 4 units. It is 160 to 200, 6 units, more than 200, 8 units. This is the basic thing. And whenever we monitor her, we monitor fasting and postprandial blood sugar. The fasting blood sugar is less than 90, and postprandial blood sugar is also less than 120. The same dose of insulin along with medical nutrition therapy should be continued. If the fasting is less than 90, but postprandial is more than 120, we have to increase the pre-breakfast insulin dose by 2 units. If the fasting blood sugar is more than 90 fasting is more than 90, we have to increase the insulin dose of the pre-dinner by 2 units. These are the guidelines given by NHM. And when the patient is on insulin therapy and institution where we have facilities to have a diabetologist, I think whenever we start the patient on insulin therapy, we get a diabetologist's opinion to put the patient on insulin therapy. We have to repeat the fasting and postprandial blood sugar every 3rd day till the dose of insulin is, till the fasting postprandial levels are stabilized. So less than 90 and 120 postprandial. But when a patient is not having regular or stabilized blood sugar, those are the patients who may need admission, so that we have to have pre-lunch, post-lunch, pre-breakfast, like 6 times we have to do a blood sugar and stabilize the patient on insulin therapy, and then we have to discharge her after stabilizing insulin therapy. So this is about insulin therapy. And what is the role of oral hypoglycemic agents? Many a times now we are giving metformin and therapy for all GDM women. Several studies have proven that both metformin and glyburate are found to be safe and effective in treatment of gestation diabetes. NHM has told metformin can be only started after 20 weeks of pregnancy, whereas DIPSI says it can be started after 12 weeks of pregnancy. But the studies have proven it is not found to be teratogenic even if it is given in the first trimester. So women who is on PCOD, the patient who is on oral anti-glycemic agent like metformin, many women are being continued to have a oral hypoglycemic agent, that's metformin in the first trimester also, and they are found to have no teratogenic effect. So both metformin and glyburate are found to be safe, but we are using only metformin in our pregnancy in gestation diabetes. The trials which compare glyburate with insulin, glyburate is found to be associated with a higher birth weight, more macrosomia, more frequent neonatal hypoglycemia. Whereas trials comparing metformin with insulin, it has been found that metformin has lesser maternal weight gain, more preterm birth, but less severe neonatal hypoglycemia. And women who are apprehensive to start on insulin therapy, metformin therapy definitely is accepted, and the women are more compliant to continue the therapy and found to have a good perinatal outcome. So that is about control of hyperglycemia. Antenatal care in women with hyperglycemia needs more higher care. We know it starts in a pre-diabetes, it starts with the pre-conception care. We have to make sure that she has an optimal glycemic control. Less than hemoglobin A1 should be less than 6.5% before she plans for pregnancy. Evaluation treatment of diabetic complications like retinopathy, nephropathy should be instituted before pregnancy, and folic acid should be given preconceptionally for all women with pre-diabetes to prevent neural tube defects. And antenatal care, like any other pregnancy, she should have regular antenatal checkup. And in the first trimester, because in a pre-diabetes, they have excess vomiting and she may have hypoglycemic peaks during the first trimester, she may need hospitalization in overtly diabetic women to have individualized glucose control. And all these women need a proper dating scan, NT scan, maternal serum, alpha protein level at 16 to 20 weeks to rule out neural tube defect. An amylase scan, fetal echo is always done, and growth scan, 2 scans, one at 28 to 30 weeks, another again 34 to 36 weeks are done for all women with diabetes complicated pregnancy. Every visit, we have to screen for hypertension, proteinuria, and other obstetric complications. After 30 weeks, the women should be advised regarding fetal surveillance by fetal movement counting, periodic fetal heart rate monitoring, and intermittent biophysical evaluation. Delivery for all these women should be planned only after 38 weeks. And women with gestation diabetes, if they have a regular antenatal checkup and the sugars are controlled, they can go till 39 weeks. After 39 weeks only we deliver. And when the woman is well controlled on diabetic diet alone, they can go till 39 to 40 weeks. If the woman is controlled on insulin or OHA at 39, we may have to do. If there are complications like obstetric complication, pregnancy-induced hypertension, other complication, earlier termination of pregnancy may be needed, but before induction of labor, patients should be put on, they have to be given antenatal corticosteroids, blood sugar control, and we have to deliver the women. So in diagnosed gestation diabetes antenatal care, similar to the pre-diabetic care, and we need intense monitoring for macrosomia, pre-IH, and monitor for abnormal growth. About delivery, when women with gestation diabetes are planned for delivery, and when you are inducing, the previous day insulin can be taken. On the day of delivery, insulin should be withheld. And many a time, all these women, vaginal delivery is preferred, and cesareans only for obstetric complications. And macrosomia per se is not an indication for elective cesarean delivery, but it should be individualized. When the patients are having complication and baby are more than 4 kg, they say there is a role for elective cesarean section at 38 to 39 weeks of pregnancy. And these pregnancy women with GDM with poor plasma glucose control, they may have to, with the risk factor, they may be delivered earlier. So it is controversial whether you have to have an elective cesarean, elective induction of labor to prevent macrosomia. We do not do induction of labor to prevent macrosomia. We have to avoid macrosomia by strict glycemic control. In case of fetal macrosomia, consideration can be given for a primary section at 39 weeks to avoid shoulder dysplasia. Otherwise, vaginal delivery is the preferred one for all these women. Special precaution during labor, we have to make sure that the insulin and the blood sugar level is always less than between 80 to 90 milligram, less than 100 milligram should be the choice. And morning dose insulin should be withheld. Women should be monitored every 2 hours. The plasma glucose in active labor, even hourly plasma glucose level should be monitored, they say. And the patient should be on insulin infusion pump. And the rate is given as per the NHM. We have to have 90 to 120 milligram. If the blood sugar value, we need not give insulin. But if it is 120 to 140, we have to put 4 units. So you have a sliding scale. According to that, we have to put the insulin infusion pump and monitor during labor. Regular insulin is administered as an infusion during labor. And once the patient delivers, actually their insulin recommends drop drastically after delivery. So we may have to decrease the dose of insulin in pre-diabetes. In gestation diabetes, the need for insulin recommend is many a times lost. The patient, 50% of the women developing, but women with over diabetes, if they are on oral antihypertensive, oral anti-hypoglycemic agents earlier, they may need in the postpartum period. GDM women, all these women, they should, before discharge, they should have a fasting postprandial blood sugar every 3rd day of delivery, and they can be discharged. And these women should have a GTT, 70 gram GTT at 6 weeks of delivery, so that many a times 50% of the women, they can develop later on onset diabetes. And if they have a hyperglycemia, annually they should be impact GTT, they have to monitor every year. If the GTT is normal, at least every 3 years, they should be having monitored for impact GTT. So postpartum evaluation, the patient should be counseled regarding the later onset diabetes and the metabolic syndrome. They should be advised, and they should be advised for testing every 3 years in case of normal postpartum glucose screening, and annually or every 2 years if they have an impact GTT. Contraception is the one of the advice we have to give. If they have finished childbearing, we can go for permanent method. Otherwise, intrauterine device, low dose oral contraceptive pills, or progesterone only contraception are the contraceptive things of choice. As Madam told, the consequences of maternal hyperglycemia starts from in utero programming. Early in the adolescent age group, they go for obesity, and they can go for type 2 diabetes, cardiovascular disease, and things. So transgeneration programming, all these are needed. All these are mainly lead on to type 2 diabetes in the both for the baby in utero. So we have to have a good control of maternal hyperglycemia in pregnancy to have a good maternal outcome. So optimal maternal diabetic control at all stages from pregnancy planning to the postnatal period is critical to the various outcome. So we have to have avoid fetal hyperinsulinemia, which will be associated with good maternal and fetal outcome, and later development of avoidance of later complication. Thank you for providing me. Thank you, madam.
Thank you, madam. It has been so elaborate, and so it has been very nice to hear everything about diabetic management. Over to you, Josephine.
Thank you, Dr. Srekha, madam, for giving this opportunity. I think next topic is also on panel discussion of management and hyperglycemia and pregnancy. So I just have to put the thing. Thank you.
Thank you so much, Madam Premlata. If the chairperson has any comments, you can go ahead. Whether the second chairperson has to make some comments. Otherwise, yeah, please let me know. Otherwise, we can go ahead with the panel discussion. So, Saiti, can we have the panelists here? Is somebody going to introduce the panelists, or should I do? Yes, Dr. Gundali.
Yes, ma'am.
Yeah.
We welcome on behalf of AMOGS and OGSSI 2023, Dr. Sneha Boyer, who's going to moderate the session on hyperglycemia and pregnancy, and we, Madam is Foxy Breast Committee 19 to 21, and SA4G Working Group member, founder, president, Vidarbha ISOPA, and she's received SN Malhotra Individual National Award for Outstanding Work, Dr. Durusha Distinguished Communities Award in 2022, and Dr. Anandbhai Joshi State Award by Government of Maharashtra. He's got 30 years of experience in obsgyne and more than 300 talks and orations and national publications.
Thank you.
Next slide. We have Dr. Shanti Gunasingh ma'am, who's the President, Chennai Menopausal Society, past President OGSSI, a well-known speaker and who has never said no to any of the talks which has been given to her, master trainer of tubal microsurgery, lactation management and adolescent health. She conducts an adolescent health program, and she's a part of Safe Motherhood Committee as well. Next slide. We have Dr. Cynthia Alexander, madam, former director, IOG, superintendent of Government Hospital. She is the president of DIPSI now, Life Achievement from DIPSI at Lucknow, and Times of Indian Economics Times Award, New Delhi 2018. Next slide. We have Shravya Manohar, consultant OBGYN, Apollo Hospital, clinical fellow, St. George's University 2021-2022, fellowship in minimal invasive surgery, and has presented a lot of papers. Next slide. Special interest in high-risk obstetrics. And Dr. Nitya, who's a consultant from Madras Medical Mission, Safe Motherhood Committee member, and special interest high-risk obstetrics and reproductive medicine. She is my right hand, probably, I would say that. And Dr. Sirisha, she's an associate professor from Sri Ramchandra Medical College, fellow in minimally invasive surgery, fellow in artificial reproductive techniques, New Delhi, and authored a chapter and a lot of publications. Next slide. We have Dr. Mahalakshmi. She's a senior assistant professor from KGH, A.L. Mudaliar Travel Fellowship, was obtained at A.L. Mudaliar Travel Fellowship and Advanced Fertility Training at SEMAR, Advanced Diploma in ART from Germany, and published many research articles. And areas of interest, again, high-risk obstetrics and gynae endoscopy. Next. We have Dr. Preeti Singamani, UG at Chengalpet, PG both from MMC, presently an assistant professor of KGH, and she is in government service for the past 15 years. We have Dr. Karthika Prabhu, professor from SRM Medical College, undergraduate and a postgraduate teacher, special interest again in high-risk pregnancy, endoscopy and midlife health, and awards like Uma Chukai Memorial Gold Medal and Asha Bakshi Award, and a gold medal research from SRM and A.L. Mudaliar Traveling Fellowship. Next. Yes, madam. Over to you, ma'am.
Yes. Thank you so much, Dr. Kundavi, and I welcome all the esteemed panelists here. I would just quickly take you through the case scenarios, and I would like to congratulate first the speakers who have, presented their excellent presentations, Madam Indulakshi as well as Madam Premlata. So I welcome all the panelists who has been already introduced. And yes, definitely, this is a very, thought-provoking discussion. I'm sure we are going to have the case-based scenarios. I would just say that hyperglycemia, which whatever form it may be, either a gestational diabetes mellitus or type 1 or type 2 diabetes, I mean, whatever way it presents, if it is diagnosed before, if it is diagnosed during pregnancy, whether it was present before pregnancy or it just manifests during pregnancy. So if you can just diagnose for the first time during pregnancy, you label it as gestational diabetes mellitus. And of course, if you know already that she's got diabetes mellitus, pre-existing diabetes, that's a over diabetes which continues during pregnancy. All of you know this, so I'm going to skip this theoretical aspect. I would just ask Dr. Nitya, what is the impact of hyperglycemia during pregnancy on perinatal as well as maternal outcome? What I mean to say is, why are we worried so much about the hyperglycemia in pregnancy? Dr. Nitya.
Good evening, ma'am.
Good evening.
Coming to the impact of hyperglycemia and pregnancy, so there are various fetal and maternal risks that are involved. Yes. So coming to the fetal risks, I would say there are risks in each trimester. So starting from increased chances of spontaneous abortions and increased chances of congenital anomalies if the sugars are not well under control, or even chances of having macrosomia and having a preterm delivery, or having a stillbirth, increased chances of IUD or a stillbirth, and even during delivery, chances of having macrosomia and hence having birth injuries because of that, and shoulder dystocia, and post-delivery, the increased chances of neonatal hypoglycemia, hyperbilirubinemia, and long-term effects as obesity, metabolic syndromes, and so all these risk factors are there for the fetus. And the maternal risks, so like it was discussed in the previous session, the infections rates are very high in pregnancy for mothers with hyperglycemia. Mm-hmm. And also there is polyhydramnios and increased, induction of labor, which also indirectly increases the cesarean section rates, and increased uterus atonia of the uterus, causing PPH, and increased maternal injuries for the mother, and
And when for type 1, type 2 diabetes, and if it is not under control, there is progression to retinopathy, nephropathy.
Exactly.
And as there are so many problems with both the maternal and the fetal, I think we're a little more worried for hyperglycemia.
Yes, so definitely you have covered almost most of the perinatal and maternal complications, short term as well as long term. Only thing amongst the mother, for the mother, I think possibility of hypertensive disorders during pregnancy can be one of the complications. And of course, as you have rightly said, because of the preterm labor, sepsis, and the large size baby, the chances for an obstructed labor and the associated morbidities, and the operative intervention and the related complications, definitely, it worsens the prognosis of this mother as well as fetus. So coming to Dr. Shavya, we will have this first case for discussion. You have this Mrs. C, who is just 22-year-old primi gravida. She's coming to you for the first time for antenatal checkup. You diagnosed she's got 10 weeks pregnancy. When you examine, her height is 152 centimeter, weight is 69. Her BMI is 30, so she doesn't have any family history of diabetes. Dr. Sharma, I would like to ask you, does she need screening for diabetes? And if so, then what screening test should be used for her?
So yes, ma'am, absolutely. I would definitely say she needs to be screened for diabetes.
May I know the reason why she should need?
So BMI being 30, that would be one of the
Is that the reason? Is that the reason? See, if I just remind you that previously, we had that elderly gravida, age above 35 years, family history of diabetes mellitus, maybe PCOS and obesity. These were few markers where we used to go for screening for diabetes, and we used to call this as a risk screening, only the high risk women. But now that all of us have heard and we have come to a consensus saying that every woman during every pregnancy should be screened, what we label it as universal screening for hyperglycemia in pregnancy. So I think it is not the risk factor per se, but it is universal screening, right?
Yes, given that her ethnicity is probably Asian,
yes,
that itself is a factor. Like Anjalakshi ma'am had said, there's 11-fold increase in the chance of diabetes. And also, in addition to that, her BMI is also on the higher side. So given this, yes, we would definitely screen. And when we would screen, I would say right away, because she's in her first trimester, we wouldn't delay any further. And the screening test, we personally go ahead with WHO, the 75 grams fasting and then 2 hours. But another test that we should look at would be the DIPSI, where we give, just 75 grams of glucose, irrespective of their fasting status.
Yes, because you have variety of tests, right from 50 grams, 75 gram, 100 gram, and you have various organizations, the American Diabetes Association, the Indian Diabetes, and so many other organizations recommending you the different tests. And of course, yes, we have come to a consensus that 75 gram glucose single test, should give you visibly the diagnosis of GDM, if at all it is possible. When should we do? You have already answered at the very first point of contact. And when should you repeat it? When should you repeat it?
Around 24 to 28 weeks, ma'am, if the first test is negative.
Right.
Then
so, madam,
again,
tell me. Then go ahead.
Yeah. And then again at around 32 weeks, if again the second test is negative.
Yeah, you're very right. If the patient comes to you later than this, definitely you whatever time, whenever she comes to you, at least one OGSSI we have to do. So, Madam Cynthia Alexander, I would like to ask you, Madam, how to do this 75 gram single and how do you interpret it? Can you please elaborate on that?
No, as the speakers all said, it is very important. It should be done as an early test and a universal test, and it should be repeated also. So this test which we do is the DIPSI test, which is a single test procedure. Whether the patient is in the fasting stage or non-fasting stage, she's given the 75 grams glucose and her blood sugar is monitored. If it is beyond 140, definitely we put her down as a GDM. And even before 120, we screen. And if we find it is the postprandial is 120, then itself she comes into a sort of a mark where she has to have repeated screening. And that is one way of doing.
You have discussed this well, madam. Only one query I have. This is a patient who is in her first trimester, and suppose you give her a glucose and she has consumed it, but she vomits out immediately in 15-20 minutes. Madam, should we continue with the test?
Yeah. No, that day, maybe she's not able to tolerate. That day you call it off. Ask her to come again. Maybe
suppose she vomits out after maybe 45 minutes or so.
Yeah, then we doesn't make well. So we call up the test. Ask her to come after 1 or 2 days. And
Madam, if I just try to add here that if she vomits after half an hour, then it doesn't matter. We will continue with the test. That's the only correction I have to make. You have discussed it so well that yes, you have to ask her to drink or consume this 75 gram glucose dissolved in 200 ml of water over a period of 5 to 10 minutes. All these guidelines, DIPSI, NHM, Ministry of Health and Family Welfare, Government of India and FOXI all recommend 75 gram single step OGSSI, we call it as oral glucose challenge test. And definitely, as you have rightly pointed out that yes, if it is, if she vomits within first half an hour, we have to call it off and then call her on some other day. But if she vomits after half an hour, then already it has been absorbed, and yes, it doesn't make any difference to the reading per se. So now, Dr. Shirisha, I would come to you regarding the interpretation of OGSSI, the different readings, how you go ahead with. Do we have Dr. Shirisha here? Yes, I can see you. Yes.
Good evening, ma'am. Thank you for this. Yes, the onset. Actually, we have, of course, a number of tests that have been put up by different organizations, as it's all been talked about, like the IADPSG.
No, I would just ask you now, we have already started performing the OGSSI or OGTT single step DIPSI. Okay. So she has already consumed, she has tolerated. Now you note down the timing of her glucose consumption, and after 2 hours, you take her blood sample for plasma glucose levels. So how do you interpret the results?
Definitely 140 or more, 140 milligrams per deciliter or more is taken to be definitely a GDM, according to the single step DIPSI criteria, and even according to the WHO criteria for that matter. So in between 120 to 140, we might think it is an impaired glucose tolerance, and we might keep an eye on surveillance for her and maybe repeat the test again at 24 to 28 weeks.
Perfect. Perfect. So if you have the initial reading itself has more than 200 milligram, it's a over diabetes. But if it is 140 plus, then you label it as gestational diabetes mellitus, and then you manage accordingly. How we will come to the discussion later. If it is more than 120, that is between 120 to 140, then you label it as gestational glucose intolerance. If it is less than 120, then the test is normal. Why? What is the significance of this 120 to 139? You have very correctly said that yes, you have to repeat the test at between 24 to 28 weeks. Even if it is less than 120, we have to repeat. But this is a case where we have to be a little extra cautious, and we have to see whether now she becomes positive for GDM. Right. So that is how, we have come to the conclusion that we have done the test and whether she has a GDM or no. So now this Mrs. C, she comes to you. This is a question for Dr. Mahalakshmi. This patient, her fasting blood glucose, she has had her fasting blood glucose done. The fasting blood glucose level is 86. Her HbA1c is 5.6%. So does she have diabetes? Does she have GDM? Does she need to be tested again, and which test? If so, when? So I would request you to answer all the questions.
Good evening, ma'am.
Good evening.
Conscious, according to the criteria recommended by IADPSG and ADA, her HbA1c 5.6 and her fasting blood sugar 86 is under normal value.
Correct.
So she is neither a diabetic nor a GDM. But
Correct.
however, Indian population needs Indian solution. So Indian pregnant women needs a test which suits her, which is the single test procedure. So I would like to repeat the test since she has a normal value at present. I will do the single test procedure between 24 to 28 weeks.
Yes. So even if our baseline tests are normal, we would like to give her a glucose challenge test, right? So suppose your patient has GDM. Now this patient has GDM, then how do you manage her?
If this patient is diagnosed to have a gestational diabetes mellitus, first I will advise her on medical nutrition therapy and physical exercise for 30 minutes daily. And I'll ask her to come back after 2 weeks with the 2 hours postprandial blood sugar report. And if the postprandial blood sugar report is less than 120 milligrams per cent, then I'll advise her to continue on medical nutrition therapy and physical exercise, and I'll review her every 2 weeks' time. And if her fasting blood sugar, if your 2 hours postprandial blood sugar value is more than 120, then I will offer her insulin as the first choice. And I will start her on human premix insulin depending upon the sugar values.
Yeah.
And if she is not willing for insulin, my second option will be metformin.
Okay, so you will review her after 2 weeks of medical nutrition therapy and active physical exercise. And you have given the cutoffs as 120, 2 hours postprandial. Okay, so Dr. Preeti, we're coming to you now. For this patient, how do you go ahead with the investigations? You are having this pregnant lady with you. You have tested her for GDM, and these are the values. And now you have placed her on the medical nutrition therapy. So meanwhile, how do you evaluate the mother as well as the fetus? By other sugars, we are sure that we are going to monitor her.
Yeah, ma'am. Good evening, ma'am. Good evening to all. This female comes to us at 26 weeks gestation with an OGCT positivity of 168. So she's been labeled as GDM according to DIPSI criteria. First of all, I'll advise her on medical nutrition therapy, ma'am. This medical nutrition therapy, when I advise, I take care that I'm not the only person who's present. I have a counselor by my side, a diabetic nurse educator or a doctor educator, and a nutritionist. So we'll customize whatever she's supposed to have as a diet. We'll even advise her about the length of her plate, what all the plate should contain, 3 major meals and 3 snacks. And mostly it should be complex carbohydrates. All that can be advised. And according to her BMI, her caloric needs should suit her. Like if it's going to be 25, she can go up to 3,000. If it's like 20 to 25, she has to stop with 2,500. Anything more than class 3 obesity, she has to cut down to 1,250 calories. Then after medical nutrition therapy, she comes back to us after 2 weeks, as already discussed. Then if her cutoff, if she falls into 90 and 120 as expected in fasting and postprandial, she can continue with the medical nutrition therapy. Otherwise, she has to think about insulin.
Yes. I would like to interrupt you here. Meanwhile, how do you evaluate the fetus? That is what we are discussing.
Okay, ma'am.
Fetus and the mother, how do you monitor?
Okay, ma'am. She has to come to our clinic. As far as glycemic control is concerned, if without insulin therapy, it is every 2 weeks. With insulin therapy, it is 3 days to 2 weeks as far as her glycemic control is concerned. Then we'll be monitoring her weight gain, her blood pressure. 30% of GDM mothers will turn hypertensive. So we have to monitor her blood pressure. As far as his biochemistry is concerned, we'll have to monitor her liver function test, renal function test, serum, uric acid, calcium, electrolytes, all the PIH profile. And finally, she should be subjected to ultrasound and Doppler measurements, wherein we'll have to monitor the growth rate, especially 20 to 28 weeks. The growth is very fast, and then only we'll be monitoring whether she's going into macrosomia, and macrosomia can be an indicator of a poor glycemic control. Therein we can advise her to get into a tight glycemic control, wherein the further intrapartum and postpartum complications can be prevented. So she'll be under constant vigilant monitoring.
Yes, definitely. Only thing what we have missed on is the first trimester scan, which is very, very important, the 11 to 13 weeks. I would say biophysical and biochemical markers, because we are already saying that this lady is more prone for hypertensive disorders of pregnancy. So definitely right from early pregnancy we have to keep a watch On the on one side, you have to see the fetal soft markers, anti-scan spatially, and the other markers. And of course, for PIHES, the uterine artery pulsatility index, that you have to keep a watch on, and the biochemical markers, the dual markers, SFLT and PLGF, if at all you have the facilities available. So I think right from early pregnancy, and then comes the HbA1c, because at the very first point of contact, when you diagnose these patients as having diabetes or GDM, we have to GDM or diabetes, whatever you're just catching her for the first time. That is the time where you go for HbA1c. What is her, status over last 3 months? Because this is a time where you have to advise her. You have to tell her, inform her that what are her chances for congenital malformation. So what is the level like? When would you like to, terminate or avoid pregnancy? How do you advise the lady for the HbA1c levels? Dr. Preeti, you can continue with this.
Ma'am, I missed the question in the middle. I'm very sorry, ma'am.
I'm just saying that, yes, you have these HbA1c levels that once you diagnose the patient having GDM, then you evaluate the mother as well as the fetus. For the fetus, we have discussed the early pregnancies, 11 to 13 week scan for the anomalies, that is the early fetal markers, soft markers. And then, of course, the biophysical and biochemical markers for hypertensive disorders of pregnancy. But at the same time, you have to do HbA1c levels because...
Yes, ma'am. That especially in the early pregnancy, wherein the rate of malformations are very high. When the HbA1c values are more than 9 to 10, the rate of malformations are more than 30%. So especially for type 1 and overt diabetes, we advise HbA1c in early trimester. But then it has no role in the follow-up of the mothers once they're being diagnosed or labeled as GDM.
Perfect. That is what the message we have to go. It has no role as far as the monitoring of the sugar levels and the prognosis of the maternal outcome is concerned. But in fact, it is for the perinatal, rather the fetal complications or fetal malformations. Because if it is more than 10, you have to warn the lady that you have a very high chance for congenital malformations, and that is a time where you have to inform her, take an informed written consent, otherwise she can blame you later and sue you sometimes. Okay, so what are the therapeutic goals like? What we have already, you have very nicely explained that she can land up into nephropathy, neuropathy, retinopathy. So we just skip this theoretical aspect. So you have a patient who is diagnosed as having GDM, and you have taken her ahead, MNT, after 2 weeks, you have controlled her sugar levels, you have evaluated the mother and baby both, saying that at least there are no malformations and the HbA1c is in the safe range. Okay, so we have this second case now, Dr. Karthika, for you. We have this primary gravida, 16 weeks. The parents are diabetic and she comes to you with the following report. Glucose challenge test, her report is 179 mg/%. What next? That means how do you carry this pregnancy and evaluate the mother as well as baby?
So she is a case of gestational diabetes mellitus. So we have to put her on medical nutrition therapy. After 2 weeks for blood sugar, you have to do a fasting and postprandial blood sugar levels. And if fasting is more than 95 or postprandial values of more than 120 mg/dL, we may have to start our insulin. And as we told earlier, so we can do either self-monitoring blood glucose levels also can be advised with 4 readings, fasting and postprandial values 2 hours later. So once the sugar levels get under control, the sugar levels can be monitored once in 2 weeks, in the up to 28 weeks. After that, it can be monitored every week.
Yes, we will come to the details of discussion for the monitoring of sugar levels. I would ask Madam Shanti Gunasinghe, what diet modifications in details you would like to recommend to the lady, and how do you calculate the calorie requirement specifically for her? I mean, what are all the parameters you considered personally for calculating the calorie requirement? Madam, you can throw some light on this.
Good evening, ma'am. So the first thing is, she has to avoid all simple sugars. That we have to be very clear about. So the white sugar, and then now so many people have the habit of thinking that brown sugar is okay. we should understand that 2 teaspoons of white sugar, if it contains 6 grams, then 2 teaspoons of brown sugar contains 4 grams. Not much, a little bit less, but not much. So she has to avoid all sugars, including honey. All these things have to be avoided.
Yes.
Then calculation of how she eats will depend on one, her gestational age. More than that, her BMI. That is very, very important. That is a pre-pregnant BMI. That itself will tell us how much weight gain she should have during pregnancy. So that itself will give us an idea. So the trimester of pregnancy also is very, very important. So suppose if she is this one can be still an underweight woman. In that event, we have to still talk about having lot of proteins in a diet, and calorie count also is more. But otherwise, if she is overweight or normal, then the weight gain should be according to the Institute of Medicine. And if it is obese, then we just say 5 to 7 kgs enough. So accordingly, we should give. We should stress on complex carbohydrates. Like suppose if it is whole cereal, that is brown rice, okay, oats or ragi. So all these things will take a longer time. So we'll bring down the postprandial glycemic excursion upwards. So all that is important. And also we should educate about food of low glycemic index value. So that will also prevent sudden increase of blood sugar. So we should talk about more of these cauliflower, beans, all these things which really do not have much glycemic index. Then we should also counsel her on fiber content. So at least 28 grams. So if she eats the fruit as such and not drink juice, then probably the fiber content will really not increase the sugar much. So we have talked about carbohydrate, which is about 35 to 50% more of complex carbohydrates with more of fiber and less GI value. Then we have to talk about protein to her. So that will be about, that depends on the gestational age also. So 1.2 gram per kilogram per day at 16 weeks and nearly 1.5 if it is at 36 weeks. So we should ask her to have a smaller plate and then fill up more with green leafy vegetables, avoid tubers, and concentrate more on proteins also like soya, animal products. When we talk about fish, we say that better to have the medium-sized fish, which are much better, which do not have much of mercury. All these large fish are said to have more of mercury. Then fatty acids, 20 to 35%. Saturated fatty acid should be less than 10%. ADA says only 7%. Then monounsaturated fatty acids. See, in West they use olive oil, for us peanut oil. Polyunsaturated fats in the form of medium-sized fish and soya. So all these things can be used, and better to avoid the sweeteners during pregnancy. But then although it is permitted, but better to avoid sweeteners. So we will always tell her you use the locally available food and locally grown fruit, and fruit also, fructose only 1 fruit per day. Yes. Mindful eating, all these things will go a long way. So 3 main meals, 3 snacks. Okay. Perfect. So all that will go a long way in management of this.
Yes, very well discussed and very practical tips you have given, madam. I would just sum up by saying that pre-pregnancy weight has got a lot of significance here. If, depending upon her pre-pregnancy weight, what is her BMI? So if she is a non-obese type of lady, 35 to 40 kilocalorie that is allowed, and if she is an obese one, 25 to 30. So pre-pregnancy weight or BMI, her level of activity and how much weight gain is allowed. These are the factors to be considered. So if she has her sedentary work, then only 350 calories are allowed in addition to 1900. If she's got a heavy work, then 2850 plus 350. So that is how the calorie requirement is allowed. And of course, considering her BMI of 18.5, the energy requirement as per the level of activity, as we have discussed here, for the underweight and the sedentary workers, it is 2250 plus the 500. But for normal weight, it is the energy requirement as per the level of activity, what we have discussed here: sedentary, moderate, or heavy exercise. And for obese, the energy requirement as per the level of activity. If it is a sedentary activity, definitely only 1900 plus the 500. That is how we have to allow. Of course, as you have rightly said, that this is how the food replacement is suggested. You have very well said it, that food having low glycemic index should be preferred. Carbohydrates should be minimum. In fact, it should be complex carbs and not the simple carbs. And of course, protein should be a major bulk of your meal, and of course the non-starchy vegetables. So very well discussed here. Madam, suppose after 2 months, 2 weeks of MNT and physical exercise, if this lady doesn't have, but before that, I think we consider what kind of activity, just in short, somebody can just throw a light. How much activity for this pregnant lady with GDM? Anybody can take up. This is a question for Dr. Nithya. Yes.
Yeah, so as an exercise, we can advise the patients. A moderate intensity aerobic exercises like a simple walking would do. So we advise the patients to start with at least 15 to 20 minutes a day and gradually increase it to at least say 30 to 45 minutes. And usually we do not advise more than 45 minutes to continuously. So summing up to at least 150 minutes per week is recommended.
Yes.
So
5 days a week, how we take it as maybe weekends off. That is how. So MNT, you have done advice monitor for 2 weeks. Then you have come to the postprandial glucose level of more than 120, suppose. Then how do you go ahead with this patient when we put her on insulin or medications? We will discuss in the next patient. Now you have this 20 weeks primary gravida. Parents are diabetic, and she comes to you with the sugar reports of 95 mg% fasting and postprandial 175. Dr. Shravya, how do you go ahead with this?
This is a completely new patient, ma'am, or follow with the previous?
No, completely new patient.
Okay. So now, obviously, because of her sugar level, she is diabetic. So we would consider her to be gestational diabetes mellitus. And given her values, we just start off with the medical nutritional therapy and exercise, and then monitor that for 2 weeks. If as long as her fasting is less than 90, 1 hour is less than 140, 2 hours is less than 120, we'd wait and watch with the same, ma'am. If if it's not under control, then that's when we would consider oral hypoglycemic agents and insulin, depending on the values.
Yes. How do you choose? I would ask you that with everybody is talking about insulin as the first line of drug when the MNT fails to control the glucose levels. When do you go for oral hypoglycemic agents, and when do you choose insulin? What is your criteria? Rather, what is the recommendation?
So insulin would be a preference more than oral hypoglycemic agents. And if the values are under control, where the fasting is more than 95 and postprandial of 2 hours is more than 120, and it's not getting controlled with this medical nutrition and the exercise, and also if it is if she started off as a little bit overt, then we would directly start on insulin.
Okay. Anybody else wants to discuss this? Dr. Preeti?
Ma'am,
the recommendations for metformin was previously only for the second trimester, ma'am. But now, given the allowance of metformin since 12 weeks itself, whether a patient obese, like the adiposity and obesity being the high risk factors, if they're already on PCOS and they're on metformin, they can very well continue metformin, and we have achieved good control with metformin, and glyburide or glibenclamide also can be added. But the problem is the compliance of the patient, and with very non-compliant patients or those patients who won't follow up with either metformin or insulin, the admission is followed. But then there are no stringent values wherein you can differentiate on OHA and insulin, ma'am, as of now.
Yes, perfect. So in other words, I would like to ask you, how do you select your patient? See, yeah, if you have this criteria that your patient doesn't respond to MNT, you have to put her on some medication. So because for insulin, you need multiple glucose testings, right? Multiple readings of glucose in a day, because you want to avoid hypoglycemia, because you need to go for 6 point or 7 point of testing initially till the control is achieved. So that is a criteria where, you know, in the rural settings where you don't have the facilities for testing repeatedly, the women are not very well educated, you don't have the dietitian or even the healthcare provider to go ahead with the testings repeatedly, that is the time where you have to select the oral hypoglycemic agent.
And
now,
more so,
yes.
And sorry, ma'am, and more so with self-monitoring of blood glucose coming up with the urban and the semi-urban setups, we can very well advise oral hypoglycemic agents. We need not be silver.
Yes, that is what I'm trying to say, that when there is a question that you don't have the facilities for testing, the woman cannot do herself self-testing of blood sugar level, then that is an indication to start with the oral hypoglycemic agent, and that this is a reference for that. Even though metformin and insulin, they are the well accepted medical management for pregnant women with GDM, not controlled on MNT. Though we say insulin is the first drug of choice, metformin can be considered as a drug of choice after 20 weeks. That is what initially it was said. But nowadays, you have the dilemma that the obese PCOS patient who is already on metformin, and she becomes pregnant. Now you are continuing her metformin. So the long-term data which is available here says that metformin is equally effective and safe. And that is how the consensus has come. All these, organizations, have a look here, ACOG, ADA, CDA, IDF, and NICE, all of them, nobody has said that metformin should not be used. So all of them are saying that it is equally effective and safe as well for the use. That is what we have come to the conclusion, that yes, though insulin is the first line of treatment, oral hypoglycemic agents are equally effective. Now, in addition to insulin, suppose sometimes you may have to add oral hypoglycemic agent, and here the indications are even with larger doses of insulin, if the patient is not responding, you may have to add oral hypoglycemic agent. Sometimes the woman is gaining weight excessively. In that situation, you may have to add insulin. So with this, now we come to the discussion that, Madam Cynthia, I come to you now, that when should we start insulin? What are the levels of sugar which tell you clearly that now this is the time we should start insulin?
Now, when we screen this patient for the first time, if her blood sugar is, say, 120, we can put her on this medical nutritional therapy.
Yes.
But after 15 days, you have to repeat the blood sugar. And if the blood sugar still continues to be beyond 120, then we put her on insulin. And we can also, as this point of metformin has come now, so when patients are little worried about taking insulin, we put them on this metformin, but we can always tell them, advise them, and then and I always believe that when we start them on insulin, it is always better to go hand in hand with a diabetologist, so that we are sure about the dosage and the monitoring that is taking place.
Yes, practically very correct. You have said that when you have the 2 hours postprandial glucose levels of more than 120 mg/% after the 2 weeks of MNT, then that is an indication to start insulin. Secondly, when at diagnosis, the patient's fasting blood glucose level is 120 and 2 hours postprandial is 199, that is close to 200. That is an indication straight away to start insulin. Coming to the various testings now, Dr. Shirisha, can we have from you how do you test the plasma glucose level? How frequently it should be through the labs and through self-monitoring?
Actually, okay, lab test, it's initially one lab test is definitely required, ma'am, to confirm the diagnosis and the baseline basic levels of the sugars that she's having. Later, I think depending on the, a patient comfort and convenience and her state, educational status and literacy, whatever, if she's able to monitor her blood glucose by herself, it is a good thing to advise self blood glucose monitoring at home. And she can do a 4-value test, and the values of cutoff like a 95 and 120 can be given to her. And if more than 2 values are going abnormal, she can be asked to actually review back, which will be easier to again manage.
In fact, initially, as we have discussed, that as long as we get a good control, we have to go for lab testing, and that is for insulin 7-point testing, as we have been discussed, 1 before breakfast and 3 pre-meal and post-meal. And of course, it is established, you can, the control also is established, you can go for the self-monitoring of blood glucose, and that can be 1 fasting and 3 post-meal after each meal. So, how do you go ahead with the maternal and fetal surveillance in the later trimester? We have talked about the first trimester. So, I think somebody can take up this question. I think Dr. Preeti and who else do we have? Yes.
We will have to frequently monitor them because 3rd trimester, the complications are high, both in the maternal and the fetal side. In the maternal side, we'll have to monitor them for the end organs, ma'am. The end organs have to be monitored. Like the retinal examination, there should have been a baseline examination where we should have a repeat.
Perfect.
There should be an echocardiography done, and we should be looking at the kidneys also. So functions, kidney functions, and the structural lesions, the structural image of the kidneys also better be monitored. Then, as already discussed, 30% of GDM, we are expecting hypertensive disorders in them. So definitely every visit, they should be subjected to hemoglobin, urine albumin sugar, BP recording, weight recording. Is there any abdominal wall edema? How the edema is progressing, all that. And though the clinical measurement alone will not contribute to either IUGR or macrosomia, the history taking and clinical examination still holds the first place in the diagnosis of the complications that are expected and not expected to both. So definitely the fundal height and the Leopold's maneuvers definitely should be given to all the females, and especially the growth chart plotting, ma'am. Definitely we'll have to plot in the growth chart, and especially in the Indian setting, we have dipped from 4 kg and 4.5 kg of ACOG to 3.5 kg from Balaji et al. Studies. So the growth chart plotting only, the serial monitoring only will give us a clue regarding whether she's going in for macrosomia or
serial cephalometry, serial growth scan is required.
Exactly.
Yes.
And if she's going in for fetal growth restriction also, we can pick it up if there is any associated vasculopathy that can be picked up, ma'am. So apart from the first trimester scans, then we'll have to go in for growth scans repeatedly. And the biophysical profile has to be always done. That should be kept in mind, the AFI and the biophysical profile, because we are expecting amniotic fluid disorders, whether associated with hypertensive disorders to go in for oligo, or the usually expected polyhydramnios in a GDM setting, ma'am. So thank you, ma'am. And Doppler studies also.
Yes. So now, Dr. Mahalakshmi, we come to you. See, from every case, we are trying to discuss a different aspect of the management. So we are coming to you here. We have now this case of primary gravida, 33-year-old with 7 years infertility, obese PCOS, conceived on treatment, continued metformin, how I was discussing, diagnosed GDM at the very first visit. She's controlled on MNG. HbA1c done is 6.9 at 33 weeks. She's developed macrosomia. The patient who is under your treatment right from before pregnancy, pre-pregnancy. she has landed up into macrosomia under your treatment. What do you think? What has gone wrong and where things have gone wrong? How you would like to manage her now? Hello. Yes. Yes, Dr. Mahalakshmi, please go ahead.
So she was advised medical nutrition therapy. And after that, she has not come for follow-up. Like after 2 weeks of time of medical nutrition therapy and physical exercise, she needs to come back to
Saiti, can we mute rest faculties?
Ma'am?
Okay, go ahead, please.
So she was advised medical nutrition therapy and physical exercise for 2 weeks, and she has not come for monitoring after weeks.
She is controlled. She's controlled on MNT. That is what it is mentioned. Diagnosed GDM at first visit, controlled on MNT.
But now her HbA1c is 6.9. But HbA1c, it is not useful for management. It's just it reflects the last 3 months sugar levels. So she might need a fasting and 4.
That is where the googly is, because we are talking about the GDM at first visit. Okay, controlled on MNT. That is after next after 2 weeks. Okay, and meanwhile, what has happened that is not mentioned here. So that is what the question here is. HbA1c at 33 weeks is 6.9, and she is diagnosed with macrosomia. So meanwhile, what is gone wrong? That is what we want to ask you.
Follow-up monitoring of this woman, ma'am. Blood sugar monitoring. Blood sugar monitoring was not done adequately after 2 weeks' time. Initially, she was controlled on MNT.
Ma'am, did she have serial ultrasounds in the period of 20 weeks to 28 weeks, ma'am?
Ma'am?
Yes, hello.
I'm not able to hear, ma'am.
Hello.
Ma'am? Yes, ma'am.
Yeah, please continue. Please continue.
Ma'am, blood sugar monitoring and ultrasound, serial ultrasound monitoring, ma'am. From 20 weeks. So she need to do an ultrasound for anomaly and fetal echo. After that, from 28 weeks, she need to...
Once again, sorry to interrupt you. Once again, I give you a clue that at first visit itself, she was already, she's obese PCOS. She was already on metformin, right?
Yes.
And in spite of that, she developed GDM. Are we missing on something?
Ma'am, she is continuing on metformin, but metformin as such, it does not prevent the GDM.
Yes.
So it needs intense monitoring.
So is it the time to start the insulin straight away?
No, ma'am, after 2 weeks' time.
After 2 weeks' time.
She can have metformin, ma'am. We can increase the dose of metformin. If she is already on metformin, so we can increase the dose of metformin, maximum of 2 grams per day. And if with metformin, if she is not, if her blood sugar levels are not under control, then we can ask her to take additionally insulin. In addition to metformin, she can take insulin.
Okay. I just clarify you once again. GDM, when you diagnose, give her a trial of 2 weeks on MNT. That is when she is not on any medication. And if she doesn't respond to this, you put her on medication. Okay.
Yes, ma'am.
Now she is already on medication to which she is not responding because she is still having high blood sugar levels. So this is a time where you have to increase the dosage of metformin. Agreed. If not, then you have to add insulin or you replace it by insulin, right?
Yes, ma'am.
Here at this point, something is missing. Okay. At least we agree on this that something is missing. Okay, you can go ahead.
The next question, ma'am, how do we manage?
Yeah. Please.
So now we need to manage her on 2 aspects. The first thing is controlling her blood sugar level. So we need to counsel her adequately regarding the impact of hyperglycemia on perinatal as well as the maternal outcome so that we can improve the compliance to treatment. So first we should ensure whether she has taken the drug metformin regularly and ensure compliance to that drug. And we can ask her to do regular physical activity and ensure that she is doing that physical activity at least 30 minutes per day. And then second thing is management of macrosomia. So macrosomia, we have to explain her about the problems anticipated with fetal macrosomia. So we should explain her that she can have sudden intrauterine death. And also in the immediate postnatal period, she can have problems during delivery in the intrapartum period, and in the immediate postpartum, neonatal hypoglycemia or polycythemia, hyperbilirubinemia or respiratory distress for that baby. And we have to ask her to do a fetal activity assessment by herself. So we have to educate her on how to monitor her fetal activity by fetal kick count. We can educate her to do a fetal kick count and when to report to the doctor. And we can also do a clinical and ultrasound assessment. Clinical assessment can be done every 2 weeks and ultrasound every 2 to 4 weeks and measure the biometry.
Yes. Perfect. Whatever you have described, absolutely accepted. Only one mistake by the obstetrician is missing on the first, diagnosis of GDM in spite of the metformin, where she was supposed to increase the dosage or put her or shift her onto insulin. That is one. Secondly, she was happy because, it was well controlled on GDM. Okay. So that was only for that period, but this medical nutrition therapy and physical activity should be continued throughout the pregnancy, and stringent monitoring of blood sugar level as well as maternal and fetal parameters, which we should do it regularly. That was missing, because rather than diagnosing macrosomia at 33 weeks, we could have diagnosed it earlier. That is what the only message to be given from this case. So we come to Dr. Preeti now, that one of the major concern in women with diabetes in pregnancy is macrosomia. So how does ultrasound help in detecting it? What is the earliest indicator of macrosomia? Yes.
Actually, ultrasound overall, it has a sensitivity of only 51%, ma'am. But then of all the parameters, abdominal circumference is a single most specific parameter, which increases the sensitivity to 71%. The cutoff is 350 millimeters, and abdominal circumference, because the maternal hyperglycemia leads on to fetal, the islet cells hypertrophy, fetal hyperglycemia, fetal hyperinsulinemia, then liver deposition fat. So we expect a truncal obesity, and the abdominal circumference, it's reflected. They were studies, especially to compare between biparietal diameter, femur length, and abdominal circumference versus abdominal circumference alone. And it turned out to be abdominal circumference alone is the most specific and the trustworthy indicator for macrosomia, ma'am, the most dreaded and the disaster for any obstetrician for that matter. So if you're able to diagnose it, if you're able to tight control it, and if there is a boon for us, the ultrasound is the only boon, and the abdominal circumference is the only marker then.
Yes. So the message here is abdominal circumference is the single
20 to 28 weeks is the most
reliable parameter. Yes.
Yes, ma'am.
This you have already discussed this. So we go ahead with what is the role of Doppler in women with diabetes in pregnancy, Dr. Karthika, for you.
As we all know, hyperglycemia in pregnancy is associated with increased risk of preeclampsia. So uterine artery Doppler can be used as a screening test for the prediction of preeclampsia. Whereas umbilical artery Doppler and middle cerebral artery Doppler are not routinely indicated for diabetes in pregnancy unless we suspect IUGR, as well as for monitoring of IUGR, we can use fetal Doppler.
Perfect. Perfect. So one more, that uterine arteries, we have already said that is right early pregnancy, 11 to 13 weeks, when we have talked about uterine artery pulsatility index for the prediction of preeclampsia or hypertensive disorders. Now we come to, I think we take this as the last case. Is it okay? Or should we continue? Madam Shanti Gunasinghe, Shanti Madam, over to you for this question now. We have this 36-year-old lady with previous one cesarean section. Now she's 26 weeks pregnant and diagnosed diabetic during 3rd month, and she's already on insulin. Her HbA1c is 6.5. Madam, her blood pressure is 150/90 millimeter of mercury. Clinically, you suspect small SGA for her. How do you go ahead with the management?
So this patient diagnosed to be a diabetic at
3rd month itself.
Right, at 3rd month. And now she's 26 weeks, a BP of 190, we expect diabetic women to develop hypertension more easily. But then we should verify it is just, after, because it is just borderline, we will again repeat the BP after 4 hours.
Okay.
And then if it still persists, then we label her as hypertensive disorder of pregnancy. And then we will do the blood investigations too.
Correct.
And all investigations for hypertensive disorder of pregnancy, like renal function, liver function test, then so all these things, they have to be done. And she should be put on, and ultrasound also is mandatory. Clinical itself, we are saying 26 weeks. So small for gestation age. So we should identify whether we will go through the previous scan also and verify whether it was just a SGA or it was delayed, even irregular periods or something. We will again verify that. And then we have to put her on antihypertensives. But then our
Madam,
target.
very good message from your side. Even if it is 150-90 millimeter of mercury, the antihypertensives have to be started, because previously there were few guidelines, the NICE guidelines saying that, the 150-100, that should be the cutoff point for starting antihypertensives. But nowadays, World Justice Organization, FOXI-ICOG guidelines, all of them unanimously suggest starting antihypertensive for 150-90 or even 140-90 millimeter. 90 millimeter of mercury.
Our target should be 135-85. It should not come down much also, because already it is a case of AGA. Sugar is also uncontrolled. That is, HbA1c is 6.5. So we will review her diet, review her activities. Then accordingly, we have to adjust the dose. Then,
Madam, here, sorry to interrupt you, madam. Here, I would like to ask you one more thing. Blood pressure is 150-90, and you are advising her all the battery of tests, including liver enzymes. Madam, what do you feel, whether this is a severe or non-severe hypertension? How do you categorize this from these investigations?
Yeah, see, this is probably non-severe. So severe, we usually say 160, 110, but then this is a complicated one. That is, when there are two comorbidities together, then we have to take cognizance of that fact also, and especially when it has affected the baby too. So we have to think about that. So we have to give more credence to all those things.
So one more message I would like to give you from here, this platform, that World Justice Organization has classified hypertension into only 2 categories: non-severe and severe. Blood pressure is not the criteria for severity per se. Okay, so previously we used to have 140-90, 150-100, 160-110. Nowadays, blood pressure is not the criteria for categorizing it as severe or non-severe. In fact, the battery of tests we are doing here, liver enzymes, liver and renal parameters. These are the ones, if you have the severity parameters, if you have the alarming symptoms, if you have impairment in the liver and renal functions, and if you have the derangements in the platelet count, then of course you have to classify. In spite of blood pressure having 150-90, if you have one of these, then you classify this as severe hypertension. If you have all the investigations normal and blood pressure is 150-90, then you label this as non-severe hypertension. Thank you, madam. Go ahead.
So we will be plateau, since this is an early onset fetal growth restriction, less than 32 weeks. So we have to monitor with umbilical artery Doppler. And probably ductus venosus will tell us if it is really, there is any downhill course. And also CTG also to a certain extent can help us. So with all these monitoring, if we have to weigh the benefits of not right now. We will just continue. follow it up with frequent Doppler and see the growth also, and then decide on termination probably earlier. Since she's a post-cesarean pregnancy with 2 complications, she will end up only in C-section. She will need antenatal steroids also, and if it is less than 32 weeks, probably max self-2 for neuroprotection.
Perfect. So that is what this slide has said, that yes, because she's got lots of risk factors, right? Age about 35 years, and previous cesarean section, diagnosed GDM very early during 3rd month, development of preeclampsia, and of course fetal growth restrictions. So we have to pay attention to each and every aspect, and we have to do maternal as well as fetal monitoring. We have to pull on this pregnancy as much as we can pull on in the safe limits. The moment you feel that it is not going to continue further, you have to be ready with delivery of the fetus, antenatal steroids for lung maturity, and prophylactic magnesium sulfate for neuroprotection. And of course, if the fetal jeopardy is there, then you have to deliver by whatever way. Should we go ahead with the next case? Or I think, I think it is too late now. I would just, Madam has already discussed all this. So I would just give you whatever the take-home messages here. We have already, the moment the pregnant woman comes to you, you have to go for the single step, 75 gram glucose, what we have discussed earlier. If the 2-hour post-glucose blood glucose level is more than 140, you label her as having GDM, manage accordingly. If you don't have the blood sugar levels are less than 140, then she's non-diabetic or no GDM. That you have to repeat at 24 to 28 weeks, and then even if later 32 to 36 weeks. Now, once you diagnose this patient as having GDM, you put her on medical nutrition therapy, that is diet modification, and your caloric requirement should be as per the pre-pregnancy BMI, the level of activity, and the weight gain. So all these 3 things you have to apply and give her a specific diet, which is to be, explained in a practical way, considering individualizing each and every individual, her socio-cultural habits, vegetarian, non-vegetarian, etc. After 2 weeks, do her 2 hours postprandial glucose levels. If they are more than 120, you have to put her on insulin or whatever medication convenient. If it is less than 120, you continue her on medical nutrition therapy throughout the pregnancy and even later. If your blood sugar levels are more than 120, how do you put her on insulin? That simple way it has been given, that if you have the levels between 120 to 160, 4 units, 160 to 200, 6 units, and more than 200, 8 units. And then you have to monitor. At any point of time, your fasting blood sugar should be less than 95 milligram percent, and your 2 hours postprandial glucose level should be less than 120. That is what your endpoint should be. So continue the same dosage of insulin, MNT, physical exercise. Meanwhile, you monitor the maternal parameters, you monitor the fetal parameters, take her to term or whatever point you can take maximum. The moment you feel that there is fetal jeopardy, prepare the fetus with antenatal steroids and magnesium sulfate. So the key message is advocacy and adherence to the protocol for testing, hypoglycemia in pregnancy as universal testing. To all the pregnant women, we have said every woman during every pregnancy, single step, 75 gram glucose. Allow her lifelong lifestyle modification, advise her lifestyle modification, which should be lifelong, because as you have discussed, almost 5 to 20% of these women down the line 5 years, they are going to be over diabetic. And that's how the message here is in our country. And of course, insulin is the first drug of choice, but considering the infrastructure where and the low resource country like India, where you do not have the facilities for even guiding the practical management of diabetes, you don't have facilities for testing repeated blood sugar levels. metformin or any other oral glucose, oral anti-diabetic or oral hypoglycemic agent is equally safe and effective. That is what the message is. And with this, I thank all of you for your active contribution to this discussion. And I thank the organizers, especially Dr. Jairani, Dr. Kundavi, and the entire team of OGSSI. Thank you so much. Once again, I just say that I'm Dr. Sneha Huyar, and I have been, contributing to academics, maybe through breast committee previously as chairperson, and then I was a governing council member for ICOG. My passion is academics, though I'm a hardcore obstetrician practicing for last 31 years. Thank you so much. Thank you so much.
Thank you, ma'am. Thank you. That was a lovely panel, ma'am. Thank you so much.
Sneha, it was a wonderful panel, Sneha.
Thank you so much, madam.
Thank you, Dr.
See,
Sneha.
one thing I want to add.
Tell me,
One thing I want to add, Sneha, that is in the monitoring now facilities are available for continuous blood glucose monitoring.
Yes, madam.
So,
I would like to. Yes, madam. Please go ahead.
So wherever situation arises, then you can put them on a continuous blood glucose monitoring, and especially in the third trimester, that is from 30 weeks onwards.
Yes. So I would like to talk about this continuous blood glucose level monitoring, madam. In fact, I have a personal experience because one of my family member is having diabetes, and we are having a sensor attached to the arm. This is a very costly affair, madam. The initial sensor which we get, and you have a screen monitor. So that itself is around 10 to 15,000 initially, and every 15 days you have to change the the cartridge. So that costs around 7 to 8,000. So people like us can afford. But when we are talking about our low resource country like India, where you do not have the facilities even for self-testing, that means a simple test, such costly affairs they cannot afford. That is what our stand is, I think, madam. Thank you so much for updating the house for the continuous blood glucose monitoring. I think the affluent people can afford to use it. And in fact, for us obstetricians, whosoever can afford, we can definitely advise. Thank you, madam. Thank you so much once again. Yes.
Thank you, ma'am, for this wonderful opportunity.
Yes. Thank you.
Thank you, ma'am. Thank you, AMOGS and the OGSSI for this lovely webinar. Thanks all the senior faculties and the chairpersons who have come over here. Special thanks to Dr. Anjalakshmi Madam and Premlata Madam for the lovely talks. And the panel, I think the moderation was excellent and the panelists did really rock with, I think, the excellent key messages was given by the panelists. And thanks, Dr. Sneha ma'am, for taking us through the different case scenarios. And thanks, Sheel Sahiti and the Chitralkala for giving us the platform. Thank you so much.
Thank you so much. Thank you once again.
Thank you.
Good night. Bye-bye. Bye.